pleural effusion. I'm trying to keep this simple as an overview. So there's, just general objectives of what is malignant pleural effusion, how to make a diagnosis of malignant pleural effusion, how to approach it in terms of management, what guidelines do we use, and what is new in the literature to guide, further advancement in MPE world. So first of all, malignant pleural effusion is by definition infiltration of cancer cells into the pleural tissue. And this is important because it's typically a pleural tissue invasion, meaning that there is pleural biopsy showing positive malignant cells, not necessarily a positive fluid cytology. And that is reflected on why do we sometimes do more than one thoracentesis trying to obtain a cytology positive malignant effusion. And approximately 15% of patients with lung cancer develop malignant pleural effusion. And even the yield within the lung cancer itself is different. So for example, non-small cell, the chances of having a cytology positive effusion is higher if you are looking at adeno versus squam. And also malignant pleural effusion can complicate other kind of cancers. So mesothelioma, metastatic cancer coming from distant places to the lungs, such as breast, ovary, lymphoma, hematological malignancies. And generally speaking, when we think of malignant pleural effusion, it portends a poor prognosis. So there's this concept of paramalignant effusions, which is sometimes we do thoracentesis and it's negative. We do another thoracentesis, it's negative. Some people get like so many in different hospitals. They get even a pleural biopsy and there's nothing. And this is what is referred to as paramalignant effusion, which is basically it's resulted from the tumor, but it's kind of an indirect effect of a malignancy. So it's an indirect effect on the pleural space, such as a bronchial obstruction, mediastinal lymph node infiltration, thromboembolism related to the cancer, or SVC. And in these effusion, as I said, you do cytology, you do pleural biopsy, both will be negative. So I thought that's just to bring that up. The next is the cytology yield. So cytology is helpful, as we know, when we do when we see a pleural effusion, more helpful for some types of cancer than the others. For example, for lung cancer, it's an easy way to stage and to know that this person has a stage 4, so they don't have to go through a lot of invasive kind of diagnostic approach. And the diagnostic yield for cytology ranges from 40 to 87%. So there's different reports, but generally speaking, 40 to 60 in the first thoracentesis, and it can go up to 70 to 80% with the second thora. And that's why with observational studies, anything beyond the second is not helpful. So that's why we don't tend to do anything more than 2. In terms of the yield in terms of volume, because we tend usually to send so much volume to the lab if we're looking into cytology. So there's 2 observational study. One is retrospective, both in 2002 in chest, and basically looked at 280 patients from 1998 to 1999. And they looked at 10 ml versus 50 versus 500 versus a liter plus, and they didn't find any difference in terms of yield. That being said, it was a retrospective, so they looked into people who already had a cancer in their fluid, and they looked back. Then subsequently in chest as well in 2009, there is a small cohort, only 44 patients that they looked at prospectively, and they looked at 50 ml versus 1,000. And they found that the yield is concordant, and there is no difference between doing 50 and 1,000. That being said, the sample size again is small. It's important to note that we do the thoracentesis, we have this volume, we send it anyways because it's going to the garbage. So, might as well just send it, even though the evidence is not very suggestive. Management. So general considerations when we think of malignant pleural effusion. So things to factor in is what's the patient status? Are they symptomatic or not? What's their goals of care? What is their performance? And then type of primary. So is it a primary tumor? Is it a malignant metastatic tumor? What is the response to therapy in terms of the, is it a chemosensitive, radiation sensitive? So all of these things should be factored in making the decision of managing this effusion. And one more important thing to note as well is what is the extent of lung expansion? Do they have a good lung expansion, or is it a trapped lung? And we will get more into details to those things. In terms of management, generally speaking, we think of either observation, so do nothing, versus doing in and out thoracentesis as needed, versus doing IPC or pleurex, so indwelling pleural catheter placement, versus doing a thoracoscopic pleurodesis, or by other means, and we'll talk about the other means. So this is a simplified way of thinking about malignant pleural effusion in the outpatient settings. This is from the ATS, but not quite. This is the ATS-1. It's not very pleasant to the eye, so this is more like simplified. So when you think of pleural effusion, so you have someone coming with this chest X-ray, right-sided, large pleural effusion, you do a thoracentesis. So the first step is you do a thoracentesis because the first thoracentesis will give you so much data in terms of how to handle this in the future. So you do your first thoracentesis, you do a follow-up, and then how the patient feels after the thoracentesis, how the chest X-ray looks after the thoracentesis, and is it cytology positive or negative? These are the three things that we look at. So say if the patient is asymptomatic after the thora, and it was diagnostic versus just trying to see if it's going to be of any therapeutic use, patient had no difference, so you do nothing. You just observe them and you follow them. The other situation, you have a patient with effusion and they come in the follow-up with recurrence of their fluid, they have cytology negative with unknown primary. So in this case, you do it again, as we said, because the second thora will increase your yield potentially. So you do a second thora, it's diagnostic, good. If it doesn't, you move to something more invasive. So either thoracoscopy or medical thoracoscopy, which is pleuroscopy, and you try to obtain a biopsy. The other situation, you have a recurrence with cytology positive or known cancer. And now you're trying to think, I'm not doing any diagnostic procedures. I'm trying to help this patient for therapeutic purposes. So we think of that now, do they have a good expansion or they don't? If they have a good lung expansion after the thoracentesis, things to be offered is IPC alone versus IBC plus talc versus talc alone. If they have trapped lung and the lung is not having a good re-expansion post-thora, the only option they will have, if they find a big benefit to the drain, is to do an IPC or pleurex. Now, things to also remember that the indication also in terms of what to do is also controlled by how symptomatic they got and how fast. So if someone is getting symptomatic every 2 to 3 months, say, maybe you don't have to do any definitive therapy and you can just do in and out thoras as they go, even if they don't have, so regardless if they have trapped or non-trapped line. And the other thing you have to remember is what's the expected survival? If someone is, having a effusion every, say, 3 weeks, and their prognosis is for 2 months, and they don't mind coming for just a thora, that's another consideration, is what's their prognosis. Spontaneous pleurodesis, because I was just talking about talc, sometimes we do IBC plus talc, so there is spontaneous pleurodesis that can happen in about 50 to 70% post pleurodesis, post IPC placement. In 2 to 6 weeks, some people takes more than that, but maybe half of patients might have pleurodesis on their own. This is the same thing we were kind of talking about, but in more detail. So what is IBC or pleurex? It's a 15.5 French silicon catheter. As you can see, my arrow here, this is where the catheter go in the chest. So as you can see it here, within the pleural effusion, and the catheter is in the middle of the catheter, there is a polyester cuff. And the role of this polyester cuff is to help with epithelialization or fixation of the catheter under the skin between the tunnel, between the entry site and the exit site. And the exit site, you have your catheter drainage system. So this is where the nurses at home access the catheter and use their bottles. So as you can see here on the right-hand side, this is the tip of the catheter. The silicone will be somewhere in here, subcut, and you have the drainage system with the one-way valve to drain the fluid. Now, guidelines for malignant pleural effusion. So until 2018, for many years, the BTS 2010 was the most relevant. The BTS more or less had the same kind of approach to the one we discussed. I would highlight just that for us to know if the patient actually has driven any symptom relief or not, and how much, it should be a large volume as tolerated. So as you can see here, you try to aim for as much as tolerated. So 500 to a liter plus is a volume that you can say, oh, I did a large volume, so I should, rely on that in terms of future planning. And then after that, in 2018, which is the most relevant still, ATS 2018 and ERS 2018. 2018 was a very hot year for malignant pleural effusion because a lot of even landmark trials were actually in 2018. So I would say that one of the things that even BTS kind of brushed on that is the use of ultrasound. But I think in one of the things that ATS kind of tried to focus on and highlight is the use of ultrasound as we're moving towards, ultrasound guided and real-time guided approach for a lot of procedures in medicine. And I like the ATS because it's a very easy read, 9-10 pages, and even the summary is good enough to kind of know the approach in general. And they have it as 7 questions in a PICO format, and they try to answer these questions. So there are some recommendations for the PICO questions. Question 1, in patient with known or suspected malignant pleural effusion, should thoracic ultrasound be used to guide pleural intervention? And as I said, this is, you can see that it was like question number 1, and it was highlighted that yes, they suggest using ultrasound when available to guide your intervention for malignant pleural effusion. Question 2, in patients with known or suspected malignant pleural effusion who are asymptomatic, should pleural drainage be performed? And the short answer to this is no. They suggest if it's mainly for therapeutic purposes, it should be guided by the patient's symptoms rather than size or re-expansion or anything else. Question 3, should the management of patients with symptomatic known or suspected effusion, malignant effusion, be guided by large volume thoracentesis and pleural manometry? And as I said, you should try to get as much volume because the large volume will be helpful in determining the benefit and then the next steps. PICO 4, in patients with symptomatic malignant pleural effusion with known or suspected expandable lung and no prior definitive therapy, should you go with IPC versus chemical proteases as a first line? And if you have a non-trapped expandable, they suggested that you can go with either approach. Question 5, in a patient with symptomatic MB undergoing talc proteases, should talc budridge or talc slurry be used? And basically, the talc can be given, just since we're talking about this question, talc can be given in 2 ways. The first is by talc slurry, which is basically you mix the talc to make it more in a slurry formula, and you inject it through either the IPC if you have one, or through a chest tube or pegtail. The other way to do it is through thoracoscopy or fluoroscopy, and you do it as a budridge, and it's just you go in and it's by insufflation. So the answer to that is they favored no way over the other. And there is also some trials around that. And for the most part, there is no preferred way over the other. Question 6, in patient with symptomatic malignant pleural effusion with non-expandable lung, failed pleurodesis or loculated effusion, should you go with IBC or chemical pleurodesis? So this is as opposed to question 4, when they said you have an expandable lung. And I like the formula of this PICO because it actually gives you the indications of doing IBC over talc, which is non-expandable lung, failed pleurodesis. So someone who had actually expandable lung, you tried talc and it failed, or someone who had loculated effusion. Question 7, in patients with IPC-associated infections, so cellulitis, tunnel infection, or pleural infection, should medical therapy alone or medical therapy and catheter removal be used? And the short answer to that is we try to treat through the catheter. So say if it's just cellulitis, it's just a skin infection, you try to give a course of oral antibiotics at home. Even if they appears to be kind of toxic and they requires admission, you can actually connect their IPC to a pleurovac and try to drain them, use the TPA as well to kind of drain the effusion and the infection, try to drain it, and use IV antibiotics. If there is no improvement, you consider removal versus, change if you still need it. So I would say it's unique in that way that unlike, any line infection or catheter infection, we keep it if we can. So these are the summary of recommendations for the questions, and we already answered them. And in the same year, ARS also released a statement for the management of malignant pleural effusion. For the most part, it's around the same recommendations. It's just longer and not as fun to read. So now the next section of this talk is about what is an ABM for MPE. So few landmark trials that I'm gonna mention. So first, AMBLE trial, which is an RCT, looked at the effect of indwelling pleural catheter versus talc pleurodesis on hospitalization days in patients with malignant pleural effusion. This was published in JAMA. And their clinical question was basically, is management of malignant pleural effusion with indwelling pleural catheter more effective than talc pleurodesis in minimizing hospitalization in patients' remaining lifetime? And I would say one of the reason for this trial is back in the day when people used to get more of the talc, sometimes that was associated with an admission, at least for a day or two, to get the talc, manage their pain. So there was this issue of resources, and this question or this trial was raised. So this is a bit of background about that. And one of the things is just the patient perspective. So freedom from hospital admissions is an important goal for patients and families, especially for someone who has limited lifetime and they're just focusing on quality of life and the remaining time in life. And the objective is to determine through this trial whether indwelling pleural catheter are more effective than talc pleurodesis in reducing total hospitalization day in the remaining life in patients. So the study design and setting and participants. So this is an open label, a randomized clinical trial that included participants recruited from 9 centers in Australia, New Zealand, Singapore, Hong Kong between 2012 and October 2014. And they were followed up for 12 months. The study end date was in October 2015. And the total number of patients, 146 with symptomatic malignant pleural effusion who had not undergone indwelling pleural catheter or pleurodesis. So no previous definitive therapy. So for example, if someone had a failed pleurodesis before, they were ruled out. And the intervention was participants were randomized to 1-to-1 IPC versus pleurodesis. So the main outcome and measures, so the primary endpoint was the total numbers of days spent in hospital from procedures to death or to 12 months. And the secondary outcomes included further pleural interventions, patient-reported breathlessness, quality of life measures, and adverse events. The results among these patients who were randomized, the indwelling pleural catheter group spent significantly fewer days in hospital than those with the pleurodesis group, with a median of 10, with a p-value of 0.03. Now, the take-home message of this ample trial is among patients with malignant pleural effusion, treatment with an indwelling pleural catheter versus talc pleurodesis resulted in fewer hospitalization days from treatment to death, but the magnitude of this difference of uncertain clinical importance. And these findings may help to inform patients in terms of making choices around pleural effusions in terms of which way to go. Next trial, AMBLE-2, which looked at aggressive versus symptom-guided drainage for malignant pleural effusion via indwelling pleural catheter, an open-label randomized clinical trial. So basically, you have an IPC inserted, it's in. What should I do next? Should I do once a week? Should I do every other day? Should I do every day? So this trial tried to look at doing daily versus as needed. So to compare, as again I said, aggressive as in daily versus as needed drainages through the IPC. And the reason behind that is IPC are now increasingly being used, and they are managed at home, and they provide similar symptom control and quality of life compared to the conventional older way of talking people all the way. And the question was, should we do aggressive drainage versus the as needed, and how would that change? And one of the reasons also that some retrospective observation studies looked at that, and there was this thought that maybe doing daily versus as needed will expedite that spontaneous pleurodesis that we earlier mentioned. So the study design is a randomized multi-center open label trial. It's again kind of same countries as AMBLE-1, so Australia, New Zealand, Malaysia, and Hong Kong. And the randomization was 1-to-1 to aggressive daily or symptom-guided drainage IBC by use of an automated telephone-based voice response randomization service. And their primary outcome was, what's the mean daily breathlessness score in the first 60 days after randomization on this visual analog scale? And the secondary outcomes is, as I mentioned, because it was this thought of this spontaneous pleurodesis being expedited through this. So they looked at the rates of spontaneous pleurodesis, the self-reported global quality of life as a secondary outcome, duration and episodes of hospital stay for any cause. And this was subdivided into pleural-related versus non-pleural-related, and frequency of adverse event and serious adverse event and survival. Now, the take-home message from AMBLE-2, this study showed no difference between the aggressive daily and symptom-guided drainage approaches in improving breathlessness over the first 60 days after IPC insertion. There are no significance between the two groups in terms of pain and the days spent in hospital or survival. Serious adverse events were uncommon in either group. The aggressive drainage was associated with higher rate of pleurodesis and better quality of life assessment. So more or less, the secondary outcome was met, which is the pleurodesis being expedited. So this also opens, ways in terms of discussion, in terms of why are we doing this drainage? Is it palliation versus pleurodesis? And what treatment are we getting? And what's the hopes of the systemic therapy that we're getting? And I would say also it's important to take the patient perspective, because unlike in the US, when a lot of drainages are actually done through the patients or the family themselves, here it's mostly through home care. And it's a setup, because you have to wait for this person to come and show up. You have to do the drainage. It doesn't take much, but it takes a time of your day. So if you have plans for the day or whatnot, if you're doing it daily, that will definitely limit your quality of life in that way. The next trial is outpatient talc administration by indwelling pleural catheter for malignant effusion, or IPC plus trial. This was published in NAJM, and their clinical question is: talc administered through an indwelling pleural catheter more effective at inducing pleurodesis than the use of indwelling pleural catheter alone? So hence the name IPC plus. So should you do IPC alone or IPC with talc, and does that make any difference? So the background behind that is, if we are thinking of IPC as a mean of expediting pleurodesis, should we actually just use talc pleurodesis plus the IPC to even further expedite? And in a prior study prior to that, that applied talc through an IPC to achieve pleurodesis as an outpatient protocol, the success rate was 92%. So they wanted kind of to challenge and look into that. And the trial examines if a combination of IPC and chemical pleurodesis with talc increases the probability of pleurodesis as compared to IPC alone. So the trial design, it's a multi-center, randomized, placebo-controlled, single-blinded parallel group trial. They have two groups: IPC plus, which is talc, versus IPC alone, which is with placebo. The setting for 18 secondary and tertiary centers in the UK. They enrolled 145 that got randomized into this trial, 76 to IPC placebo, 70 eventually included for attention to treat analysis, and 69 eventually in the IPC talc group for the intention to treat analysis. And before we go any further, how do we actually do the talc? As I said, one of the ways is doing it through medical poroscopy or thoracoscopy. That's insufflation. That's different. For IPC plus, you have someone who's already having IPC inserted. And this is actually from BTS, and this is actually how you do it for chest tube, but it's not much different. So what you do, there's a center-to-center differences in the way it's done, but you try as much as you can, A, to pre-medicate the patient, B, to pre-medicate the space. So pre-medication the patient, for example, you give them a Tylenol 650 or 1,000 an hour before this, or half an hour before this. You do the same with morphine, 5 milligrams, or hydromorph 1 milligram. And then you actually install lidocaine solution. For example, you do a 2% 20 ml within the pleural space. And then after that, you mix your talc, 4 to 5 of sterile graded talc, into 40 to 50 ml of normal saline. And then you inject it after you pre-medicated already. And then you wait and you do vitals for the first half an hour to an hour. Typically, you keep them for 2 to 3 hours to make sure everything is fine. You do an X-ray, you send them home, and you follow up. So this is how it's done. Now, the primary outcome was successful pleurodesis at day 35, and the secondary outcome was successful pleurodesis at day 70. And for the primary outcome, 43% in the IPC talc group compared to 23% of the placebo group had the successful pleurodesis by day 35 with a significant p-value of 0.008. The secondary outcome at 70, 51 in the IPC plus versus 27 in the IPC alone, with again a significant p-value of 0.003. The IPC talc group had better quality of life scores. The IPC talc group had better symptom scores at all assessment points during this trial. And the hospital days until day 70 were also even 4.1 in the IPC talc group, 3 in the IBC. So it's not that much of a difference. So you cannot think of it as in it's gonna mean more medical contact or hospital stay. So from their end, it's a positive trial. And the take-home message from this trial is IBC plus demonstrated MPE without substantial lung entrapment. Treated with IBC had a greater chance of pleurodesis when you use the IBC plus approach versus IBC alone. And again, just to highlight again, these for people who don't have trapped lung, so they have a reasonably expandable lung. Next is PROMISE trial, which is, as the name implies, has some promising ideas rather than actually a clinically significant, I would say. So this is published in Lancet, development and validation of response markers to predict survival and pleurodesis success in patients with malignant pleural effusion, multi-cohort analysis. Now we have tools, we have ways, we know what we do, roughly speaking, and we learn all the time. So knowing what we know now, is there ways to kind of use to help even further prognosticate a patient and accordingly trying to help them make decisions? And the clinical question was, can a survival score for malignant pleural effusion be developed using a combination of conventional and pleural fluid-based biomarkers and be validated on prospective data? So the background, MPE is associated with a highly variable prognosis, ranging anywhere from several days to over a year. The rule, as is, the goal, as again, is accurate prognostication as an important factor for patient counseling all the time, because this is one of the first questions they always ask about, as well as the choice of management. For example, what is the relative cost effectiveness of pleurodesis versus tunneled pleural catheter placement? May vary with life expectancy. The clinician and clinical trial investigators continue to struggle in terms of accurately prognosticating the MPE patients. And we, as we said, generally speaking, if you have malignant pleural effusion in a cancer, this on its own is a bad prognostic factor. But within that, we need even, kind of shades of prognostication to help our decisions. So the study design was a multi-phase study comprising the following: biological biomarkers discovery using a mass spectrometry, clinical biomarkers discovery and model development using retrospective data, and pleural fluid samples from time 1, time 2, time 3 study cohorts, and the prospective external validation on the SIMBL study and Oxford Radcliffe Pleural Biobank. Their primary outcome is to look at the mortality at 3 months. Population inclusion criteria: patients with MPE who were at least 18 years old. Exclusion criteria: expected survival less than 1 month. So if it's like a no-brainer and it's really poor prognosis, they were excluded. Baseline characteristics: so baseline characteristics of the time 1, which with the total number in that study of 320, time 2 106, time 3 126. Cohorts have been published previously. Mean age around 70 years in all cohorts. So the outcome: a total of 25 candidate biomarkers were tested for prediction of 3-month survival. These included demographics, so age and sex, cancer type, history of chemotherapy or radiation therapy, illness severity, serum laboratory values, and pleural fluid proteins. It's better to look into it this way. So this is from MedCal, you can find it. So this is the PROMISE score from malignant pleural effusion for prognostication. As you can see here, it's highlighted to predict 3-month mortality. This is the clinical domains that are factored in. So previous chemotherapy at any time, previous radiotherapy for any time, what's the hemoglobin level, what is the serum white count level, what's the CRP, what's their ECOG performance status, what's the cancer type, and what is the TIMP1, which is it's a tissue inhibitor methylproteinase 1. Honestly, it's more of like a research kind of blood marker that we don't even use much. I have never seen it except in but just reading in studies and stuff like that. And these are the cutoffs that for significance, the higher it is, obviously, the worse. And the score, the calculated score for the clinical PROMISE score and the biological PROMISE score together gives you the 3-month mortality. So the higher the patient's PROMISE score, the higher the mortality. And as you can see, once you are more than 35, you are looking at a 75% mortality within 3 months. Again, I would say the main thing to take home message from this is, for example, this pleural TIMP1 tissue inhibitor of metalproteinase is by its own, if you do the same score without it, doesn't reflect it much. And that's why even you can see here it's unknown, so it's an option to even don't factor it in. And as you can see here in this slide, the clinical versus biological doesn't make change much, but I think it's the idea itself is neat, is if we can find something biological, similar to when we do PSA for prostate or other cancers, like we have some blood work that we can kind of use in colorectal, pancreatic. For lung, we don't have that luxury. So it's just to open venues in terms of future biochemical role in managing and prognosticating pleural effusions. So just quickly brushing on, just because we mentioned time 1, time 2, time 3 cohorts in the previous trial. So time 1, they looked at using NSAID versus opioids to see if it's going to reflect on the pleurodesis chance or efficacy at 3 months, and they didn't find any effect on NSAID in terms of affecting the pleurodesis. Time 2, they looked at among patients with malignant pleural effusion and no previous pleurodesis. There was no significant difference between doing IBC and talc. So this is an older study. Time 3, intrapleural urokinase does not improve dyspnea or pleurodesis success compared to placebo on non-draining MPEs. Again, that wasn't meant to be in detail. It's just to kind of just give a one-liner about each of them, just because we talked about them. And the resources used, as I said, BTS 2010, the ERS, ATS, up to date always, and few others. And that's it.
Great talk. Thank you so much. Does anyone have any questions?
Thank you. That was a very thorough presentation. Now, in the past, I thought that when the general surgeons used to put in the chest tubes, that you would have the patient sort of turn around one side to the other to sort of move the material around. Is that needed, or you just instill and then you just let the patient lie, whatever position?
To be honest, it's really hard to sit still for 3 hours. So usually, you just give them, as I said, pre-medicate them, at least for the first half an hour or so. You make sure that they're okay. And they can just, as long as they're in the hospital, in the unit, they can walk around, and that's fine. That's better than rolling in the bed. Yeah.
Right. And also, is there ever an indication when you would not put in the catheter on an outpatient basis that you would want to admit the patient?
Admit for talc?
Yeah, well, or for your IPC.
I mean, if after so because you're still doing it, when you do it, you have to observe them for 2 hours at least. I mean, if they're having significant pain, if they had start to have, symptoms, shortness of breath, any indication for an admission otherwise, you will admit them. But specifically for that, I'm not aware of any.
Thank you.
Thank you.
I'm not sure if you can see in the chat, we have a question from Kim. It says, with regards to managing infections and keeping the IPC with the course of antibiotics as the first step, is this only with cellulitis, or is this also the case with a tunnel infection and or pleural infection?
No, so I would say for any infection. So if it's as simple as cellulitis, you can do just a PO course and you can send them home. If it's something more significant and it's more like a catheter versus a pleural infection, you will admit them, treat them as a pleural infection, and start IV antibiotics. You connect their pleurix into a pleurivac. You can use your TBA to try and help clean it. And you just monitor, see how they do. Within 48, 72 hours, if they're improving, you just do the same and keep the catheter. If they are not, this is the time when you would consider either taking it out completely if they're not needing it, or changing it if they're still needing one.
And we had one other question in the chat. It says the IPC plus trial was single blind, given many of the outcomes were subjective in nature. Who was blinded and how was success of pleurodesis defined? Were the radiologists reporting the results dedicated to the study and blinded?
So the patients were blinded, as far as I remember, not the investigators. And the other portion of the question in nature, who was blinded and who was successful in pleurodesis defined. So yeah, so successful pleurodesis was mainly by radiographic.
Inez, it's Neil Isco. Can you hear me?
Yes.
Okay, that was me who asked that question. The question I have about the PROMISE trial is a little more complicated, but it strikes me that the results may be, I'm not sure how to interpret the results, because we look like we have a whole bunch of trials interspersed with one another, because some had interventions and some didn't. And the other aspect of this is, one would have thought survival would probably be more strongly related to performance status than some of these other features. And what happens when you put all this stuff together is you lose a sense of what's the explanatory power. There are various models for the outcomes in testis cancer way back when, and some of them were really complicated, but the simple ones held true. And the simple ones were based on a couple of things that were easily measured and carried the bulk of the explanatory power. Was anything like that looked in the PROMISE trial to try to make the whole issue of prediction of outcome something easily done at the bedside?
Yeah, I agree. To be honest, it's very heterogeneous group in terms of even including the time 1, time 2, and time 3 populations. And when I was reading it, I was mainly I thought of it as a new kind of lens into the malignant pleural effusion, trying to kind of find a way to prognosticate. But I've never even honestly seen anyone using it, even though it's a score that you can find online. But I don't think that anyone is actually reliably using it. So I think it's just for future kind of research. It's a neat idea, but not that much clinically useful at the present time.
Thank you so much. If we don't have any further questions, I think